Okay, sounds it's about time to get started. Welcome to the Nursing Home Social Work Network series. Um, Session is being recorded, so if you're not able to stay with us for the entire webinar today, please check back on the website and listen to the recording. I'd like to welcome nursing home social service workers, social workers, and anybody else who's working in a nursing home, and thank you for the important work that you're doing. We also welcome others who are interested in improving the quality of care in America's nursing homes. I'm Mercedes Bernklug. I'm here at the University of Iowa working in the School of Social Work and working on this project with a series of people from around the country, and I'll show you their names in a minute or two. Just to remind people that we've got at least two webinars per month. Our two-day webinars usually are devoted to best practice social work, real skills building with a case study, and we're open to having our BSW colleagues who are working in a nursing home present a case that you've done. So if you're at all interested in helping out on one of the webinars, please email me and we'll talk that through. One Thursday a month, we focus on an emerging issue, something that's newsworthy or that provides good background information for nursing home social services, and we invite colleagues from other disciplines to be part of the speaking panel on our Thursday meetings. The session right now is being recorded. The persons whose mics are unmuted are just the presenters and myself. Anybody else who might have called in by phone, your phone is muted, and we know that most of the people are listening through their computers, so welcome to you as well. We'll be posting the recording of this webinar by about noon tomorrow. The handouts are already posted on our website. So here's the format. We're in the welcome section right now. Soon I'll be turning the microphone over to my colleague Bob Conley, who will introduce the topic and the speakers. And the speakers will present until the top of the hour, so they'll have about 55 minutes to present, and then we'll do questions and answers through the chat box. So if you have a question, go ahead and put chat box, but I may wait until the Q&A time before I read the question, or if it's something that you'd like to have attended to quickly, go ahead and just let me know and I can interrupt the speakers. These are people who've been part of the planning committee for the last year and a half, getting the webinar series off its feet. And I'd like to introduce now Bob Conley, who's a social worker with 20 years of experience at the Center for Medicare Medicaid Services, and in fact, he was the project officer for the NDS 3.0. He's been with this project from the very beginning. He's co-leader of the webinar project. So, Bob?
Thanks. I just want to preface that I also had 4 years working in hospitals, making referrals to nursing homes, and worked very closely. And I think the topic today of managing crisis in the nursing home and emergency department referrals is very important to nursing home social workers, emergency room social workers, hospital social workers, because they can have multiple crises. Our speakers are particularly well qualified for this. When I talked to Gabrielle Langley about doing this, she said, you know, when I got my graduate education, they didn't really emphasize crisis intervention skills, and boy, did I have a quick learning curve for that. And her presentation is going to be based on her over 17 years of experience. We wanted to bring in the emergency room, emergency department, because we want to be able to look at when you make a referral to emergency room or you get an emergency room, your patient back, that often is a social worker on the other end, and that this is the crisis. So I'll introduce Gabrielle, who's doing a second seminar after an excellent one on interdisciplinary interdisciplinary care. So she's plus two. She's really been great to us. She worked at one of the largest long-term care facilities in the Gulf Coast, Texas area since 1997. Design and develop programs to help people afflicted by memory disorders. She also has a specialty in neurocognitive impairments and lectures at universities, hospitals, churches, synagogues, and the Alzheimer's Society. She's worked as a clinical social worker and psychotherapist for over 15 years. And in addition to these great qualities and the research she's doing, she also is an award-winning poet. Ronda is a licensed clinical social worker for the state of New York with experience in both foster care and emergency medicine. She's worked with multi-interdisciplinary teams. She's currently a senior social worker at the Mount Sinai Mercy Room Department, where she's been employed for 12 years. In a grant from the Centers for Medicare and Medicaid Services that I used to work at, which is a geriatric emergency department innovation and care program, otherwise known as JDY. And what's interesting about this is they create an atmosphere to do better discharge and coordination of care within Mount Sinai. And then social workers, including Liza, follow up and call people in the community to really identify how they're doing and try and avoid rehospitalizations or more emergency room visits. She has a master's degree in social work from FLIM and a postmaster's certificate in palliative and end-of-life care from the New York University and Family Counseling and Sacrament Institute. For spare time, she volunteers with Safe Haven Animal Shelter and Life Center. So I look forward to their presentations.
Okay, I'm Gabrielle Langley. Happy to be here today. I'm going to be doing the first half of this, and it will be on crisis intervention. And the first thing I want to look at is some definition and theoretical framework for this, and talk about it in general, but then more specifically in a nursing home setting. So for those of you who have degrees in social work, what may or may not know or remember is that a crisis is an event that is perceived as overwhelming, and more importantly, it's what the client as having a situation where they have exhausted all of their resources and coping ability. So you as a social worker may see that they still have resources, but it's client's perception that they don't, and that's the experience of being a crisis. Also, very important as social workers, we want to remember that what is going to be perceived as a crisis by one person is not necessarily going to be experienced as a crisis by someone else. One of the most helpful theoretical frameworks we have for understanding how clients and client systems behave in a crisis is systems theory, which is a cornerstone of social work training. What we know from systems theory is that systems, whether you're talking about an individual client or you're talking about a family system or a larger group, or even an organizational system like the nursing home that you're working with, systems typically fear change. They like to have homeostasis or stability. Homeostasis is just a fancy word for stability, and they tend to want to have that at all costs. People get very anxious when they perceive any kind of threat to that stability, and it's the social worker's role is to understand that sometimes the system needs help, because if it stays too fearful of change, it's going to go into a state of entropy or folding in on itself. So the social worker, we use ourselves by injecting into the situation to help aid the client in restabilizing. crisis intervention is different from other forms of counseling and psychotherapy, and this was when I was explaining to Bob when we talked about this program. I had come from a background of a much more traditional type of counseling and psychotherapy where the social worker had a comparatively passive role because everything was client self-determination, everything was exploring where the client was, what the client was, encouraging the client to explore that. What was not used to taking a more directive and immediate role. When I came to work at the nursing home, I was having, it was a real adjustment. I had my own adjustment disorder because I didn't have a background in crisis intervention. I actually went and did some work on it, some after my graduate degree, and it helped me tremendously in working in a nursing home setting, because it is such a different model of practice. One of the things that I came to understand and came to learn, and this is well documented, and I've heard a lot of other practitioners talk about it, is that people, when they're in crisis, they're usually going to register less than 15% of the information that you give. And so what that means is that you're going to need to provide information more assertively, and you're also really going to be needing to look at repeating and then reviewing critical pieces of information with your client. Another thing that happens is when a client that you're working with is experiencing a crisis, they will tend to feel, as we said, overwhelmed. And one of the most helpful interventions that we can do with our clients is to realize the problem. We're making the problem manageable by breaking it up. And so you're asking, as your client is sitting there panicking, what's going to happen, you think in terms of the next best thing for the client to do and then help the client maintain focus on that. Usually clients want to do something, but they're quite sure what to do. And the thing, too, is when you have a client, a family member, or a resident who comes to you and they're panicking, they're in crisis mode, one of the things that we can do is to act as a grounding agent. If you think of all of the energy that the client is spinning on the client, and we want to try to use ourselves as a grounding agent to help them some of the nervous energy that we're seeing. And again, usually what will help with that is to give the client some kind of manageable task. And I'll talk more about that in a minute, and we'll explore it a little more in a case study. Social workers, in terms of techniques that we use, the social worker can help by remembering that there is a huge difference between a crisis and a real emergency. An emergency is a life or death situation. It usually involves ambulances. Somebody is getting ready to die or may die or come to some very serious harm. A crisis is something else. Some examples. A crisis is a person who's been recently diagnosed with Alzheimer's. They wander into the family dining room during the Thanksgiving meal where they're wearing no clothes. They're buck naked, and they walk in, and all your little kids are there, and the grandkids are there. That is a crisis. An emergency is a person who has just taken an entire bottle of sleeping pills. So you can see the difference. A lot of times your clients will not understand that difference, but it is important you as a practitioner understand the difference because it helps you, again, to provide that calm and that grounding. Another thing, and this helped me tremendously in working in a nursing home setting. Every time a family would come to me with a crisis, I used to feel like I had to solve it right then and there. I had to immediately fix it. Well, the phenomenon is that most crises are going to resolve within 72 hours, even if you do nothing. So what that means for us is that a lot of times we are just being a calm witness and a friendly guide in the process, and you a lot of times don't necessarily have to find the answer immediately. The other characteristics of crisis intervention counseling is that this counseling can be provided in a wide variety of settings. The crisis intervention counseling is usually going to come up with any schedule or appointment. So this is, somebody that's shown up in the lobby of your facility that's, you get a call from the receptionist, they're crying hysterically, they need you to come up because they're paying about all the emotions that are being displayed in the lobby. So you have to go. It's an urgent call, and it's typically not something that was scheduled or with an appointment. You also very often are going to need to provide education and support to your administrators and other staff, both before, during, and after a crisis. Because remember, it's affecting the entire system. If the crisis is large enough, it will affect staff in your nursing home as well as the family and or the resident that you're working with. In terms of education in the nursing home setting, one of the things that can be very helpful is if you're having types of crises come up over and over again, it can be helpful for the social worker to become involved in drafting policies and procedures, and also in the development of in-service for educate them and help them feel more empowered during particular types of crises. A question came up in the past that, and I've had other students that I've worked with ask me about how do you document a crisis. And all times when I've seen social workers, new social workers trying to document crisis, they end up panicking themselves and they write way too much. I mean, I've seen notes that look like written novels that needn't be that long. So when you sit down to document what you've done with a crisis, keep in mind some basic techniques. And one of them that you may have heard of, and it works very well with crisis intervention, is what's called the BURP technique. And that means you have your baseline, you can write one line about that, you have your intervention, you have your response, you have your plan. So, for example, the other one is SOAP, which is similar, symptom observation, assessment, and plan. So the symptom can be that, for example, a client comes to you and that they feel helpless, that they don't want to go on living, if they have to live in a nursing home, that their life is over. And you may have, the observation could be that you and the activities staff, for example, have noticed that they have stopped partaking in any of the activities, including activities that they usually enjoyed doing. For example, music or bingo, or they used to play bridge and they've stopped doing that. An assessment would be that you're beginning to suspect the person is experiencing either a severe adjustment disorder or a clinical depression. And your plan is going to be to contact the primary care physician and possibly recommend a psychiatric consult. You also may plan to include this particular resident in group therapy if you're doing group therapy. So that type of thing. So this is what you would be documenting. So stay focused in your documentation and remember that either the BURP or the SOAP format can help you tremendously. Also use concrete and observable detail in your documentation. As we just talked about, you want to don't say things like client looks depressed. That's vague. That may be your assessment, but that's observation should be grounded in something more concrete, such as what the client said or what you're observing. Okay, a case study of a crisis. A lot of times what I noticed in my other colleagues who work in nursing homes is that families are in crisis when something is changing, usually medically, with the resident, or in the case that we have a lot of times, they're applicants that are coming in. It's usually a family who shows up in the lobby panicking. You might have somebody crying. We usually get a call from the receptionist or sometimes from our marketing director when families exhibiting way too, quote, too much emotion, and that the staff is feeling too too overwhelmed themselves to deal with all of the emotions. So they'll call myself or one of my colleagues in the building, and a lot of times there's been some kind of dramatic change. For example, the father who just received a diagnosis of dementia, and he's had dementia for some time, but he actually was brought back to the home. They were trying to take care of him at home, and they had to police had to bring him back because he took the car out and he ran it into the side of a building. So it becomes very apparent to the family that even though they've been trying to keep everything status quo, very stable, that crisis has emerged. This man's medical condition, his neurological condition, has gone past the point that the family is able to take care of it, and they're not quite sure what to do next. So an example of what you can do, they're trying to figure out what to do, and a task that very often is helpful after you let some of the emotions you spend some time with them, listen to their story, is they're agreeing that yes, he definitely needs to be placed in a secured environment. The next step that they will take is to fill out the application for the nursing home, and it can be very helpful, just to give them that next best thing to do. That can be helpful. Talked about documentation. We talked about the case study. The other thing that is very important to review is risk, to recognize that any practitioner, no matter what discipline they're in, but particularly with social workers, that they need to, and I seem to have temporarily lost the ability to advance my slide. Hold on, let me see if I can move forward. Yeah, there it is. Sorry about that. It's very important to realize that people who are around a lot of crises, this places you at tremendous risk of burnout. When people are in crisis, and of course we encounter this a lot in nursing homes, because what drives people coming into the nursing home is typically a crisis. You will notice, if you've done it for a while, that very few people coming to your door when everything is going well. Nobody wants to be admitted to a nursing home. If things were going great, they wouldn't be at your door. They wouldn't be seeking admission into your facility. So it's usually, I say about 95% of the time, it's a crisis that has driven the admission. It's that the person has fallen, they've broken a hip, or there's been some dementia-related behavior that is beyond what the family can manage in the community. There's something pretty dramatic going on. The thing you want to realize is that working with people who are in crisis, a lot of times things that they hit you with is anger. Their anger. And remember that anger is the mask worn by fear. Usually if you can scratch the fear or the anger, the person that you're dealing with underneath is terrified. A lot of times it will manifest. And in fact, when they have looked at, this was a study that was done in emergency, social workers working in emergency rooms, and they were wondering why was there such a high turnover rate. And I think you could extrapolate and look at some of the turnover rate that you see in nursing home social workers too, and thought that it was going to be the death and the sadness, the family's grief and anxiety that was going to be quite depressing and causing people to leave. And we found out when they interviewed the social workers, it's not that. We can deal with that. We can sit with people who are in grief. What we have trouble dealing with and what drove us out of that setting was the onslaught of anger over and over and over again. So find yourself around a lot of that. It's very important to realize that the anger is a symptom of a person, usually a person who's really and truly frightened. It is not about you, and it's very important to remember that and to continue to disengage from that. The other part of managing that is that when you're working with a client, particularly a client who's hyped up and really angry, slow your own breathing down, keep your own breathing very slow and deep. It will calm you, but very often you may notice that it calms the client. The client is you're using yourself as that grounding agent. You want to understand that the client's anxiety and anger may be contagious, so you don't want to become infected with their emotions, that sense of being anxious and not knowing what to do next yourself as a social worker. And you want to realize that you are not required to feel the crisis for your client. That's something that is very easy to get sucked into a lot of times when the client is getting hyper. If you find yourself getting hyper, just take a deep breath and remember that you do not have to feel the client's feelings for them. Social workers want their role as a witness or a guide, and remember that the ministry of presence is very often all that is required in situations like this. It's also helpful to shift your from solving problems to helping manage problems. So you realize that when we came into this field, we came in because we wanted, if we're being honest about it, we came in wanting to solve problems. But in the nursing home setting, we're working with many unsolvable problems, and what we mean by that is we have many incurable illnesses in the nursing home setting. These are people who are working with illnesses like Alzheimer's disease or chronic congestive heart failure for which we cannot cure it. So we shift our focus to helping the client manage those problems. And last but not least, it is very important, and I tell anyone who trains with me, any of my graduate student interns who come to train here at 7 Acres, you have to rest well and play hard. When you are not in your work setting, it is very important to be doing things that are completely different than what you do at work, and really take immaculate care of yourself. This is the way to have a good and successful career in nursing home social work, but it does take that commitment to yourself, realizing that if you don't bring your best self forward to work every day, you can't do an effective job, and you can't protect yourself in a setting in which can otherwise take a lot out of you. So I'm going to turn the staff of our presentation over to Liza, who is in the emergency department at Mount Sinai Hospital.
Thank you, Gabrielle. I want to thank everyone for the opportunity to speak today. In my presentation today, my goal is to provide understanding of the operational process and social work role in an emergency department, to help learn about changes in healthcare, such as the Affordable Care Act and its effect on emergency department discharges, how to improve transitional care to and from emergency department and nursing homes through collaboration of care, and explain the challenges we face every day and the upcoming new innovations in our medical setting. As say, a picture is worth 1,000 words. This photo depicts a common emergency department setting with people of different ages, gender, and cultural backgrounds, doubled up in the center of the room, which lacks privacy. Some curtains open and others without any at all. This thing of an overcrowded environment with possible high noise levels and bright lights is not uncommon for an emergency department. It also presents challenges for the staff that may have difficulty navigating through the stretchers while trying to maintain safety for themselves and their patients. Inability to maintain privacy, the effective timeliness of care. The environment can become overstimulating and non-conducive to the wellness of our patients. For
patients, especially our older, frail patients, this is the list of what can quickly become a crisis. I just received a theoretical framework of crisis intervention in a nursing home setting. So how crises in the emergency department differ from other settings? First, a precipitating event occurs. This be the event that led them to come into the hospital or manifested during their visit. The presence of this event leads to subjective distress, meaning they feel they are unable to resolve their current issue on their own and seek the guidance and expertise of multiple disciplines for resolution to their current problem through resources and intervention. For these individuals, the presenting problem has escalated to the point that the usual coping methods have failed, leading them to function psychologically, emotionally, or behaviorally at a different level than before the event occurred. Social workers provide frontline services to patients who enter the hospital. Crisis intervention is implemented immediately and usually very focused and intense. Social workers in the emergency department help patients regain control over their thoughts and feelings, and we try to assess the patient's capacity to focus on reality. We work collaboratively with interdisciplinary team for immediate intervention, such as a psychiatric evaluation, administration of psychotropic medication if necessary. The dynamics in an emergency department are unlike any other setting. The availability of the unit is 24/7, 365 days a year. Time of day, whether it be day, evening, or weekend hours, impacts care of the patient. Each has its advantages and disadvantages. For example, today patients have a full staff and we have more accessibility to community resources. Also predictable, patients may experience overcrowding and social workers may need to make quicker assessments. In the evening, the emergency department is usually calmer and more subdued. There are limited resources in the evening, and patients may need to wait until the next business day to obtain scheduled referrals. Some patients prefer the weekend for the convenience of social support. The timeliness of discharges can be most affected during the weekends when most ancillary agencies are closed. The emergency department is a fast-paced, sometimes overcrowded environment. Our most affected population is the elderly, who may be frail, unaccompanied, and scared. The aesthetics of our environment can affect mental and behavioral changes in these individuals. Sometimes these patients may not be in a crisis until they have been in the emergency department for several hours and then begin to experience sundowning, which is the inability to differentiate between whether it's day or night. They may even have a change in mental status and become delirious or confused. They may have a decline in functional status, such as difficulty walking after lying down for an extended period of time. Many older patients experience frustration and irritability due to constraints of space and lack of privacy. During time, social workers elicit the assistance of care volunteers, which stands for Care and Respect for the Elderly, who provide socializations to our older adults. Due to the fast-paced environment of the emergency department, discharge planning is initiated when a patient enters the hospital. This provides the opportunity for staff to focus on patients' needs and directly implement resources and referrals during their current visit. Social workers have to make quicker assessments in a shorter period of time. Or, communication among staff is an essential component to effective and safe discharge planning. Each member of the team should be mindful there are differences in communication among disciplines. For example, the patient MI would mean mental illness to us social workers and myocardial infarction to a physician. Unlike disease-based units, the emergency departments are composed of patients of every diagnosis and illness. A medical social worker not only implements the skills of their practice, but must also be knowledgeable of medical terminology. There are challenges in working in both economic extremes of wealthiest to poorest, which impacts resources and timeliness of discharges. For example, a patient with a set income decompensating in activities of daily living and personal care may find themselves in crisis if unable to afford additional services at home. Patients who enter the emergency department are from different socioeconomic backgrounds and present with a multitude of medical problems. As a worker in the emergency department, we need to quickly assess the patient's micro and macro systems and how do families function in crisis and make decisions. Social workers need to help other disciplines understand how cultural and religious practices affect the process of care. People of different cultures and religions react differently in crisis. We need to be educators to our team and inform them of our family's choices and preferences. This sometimes can impact care by either procrastinating or hindering some resources. For example, individuals of Jehovah's Witness religion do not believe in blood transfusions, or someone of the Orthodox Jewish faith will not be transferred during the Sabbath. The big change in healthcare is the Affordable Care Act, which impacts emergency department discharges. As the Affordable Care Act, hospitals are working on ways to improve better health for patients, provide better health care, and lower costs for beneficiaries 65 and over. The aim is to control healthcare costs by reducing inpatient admissions from the emergency department and reduce 30-day readmissions. To improve healthcare delivery and quality of life for patients by looking at new innovations such as the palliative and end-of-life care in the emergency department. The government is now tracking these healthcare innovations. On the horizon are direct admissions with bed hold from the emergency department, the of advanced measures, rapid goals of care. Other interventions include promoting better health, reducing functional decline in patients, guiding care transitions, and improving coordination of care. There is pressure on emergency departments to decrease admissions while simultaneously decreasing patient and caregiver stress. There is also pressure to provide safe and appropriate discharges in a timely manner. Hospitals will not receive financial payment for patients who return and are readmitted within 30 days. As we focus on transitional care as part of our healthcare innovation, we are looking more closely at transfers between emergency department and nursing homes. The older patients are most affected by these transitions and account for a high percentage of transitions. With cognitive and functional impairments and are unable to communicate, which makes them the most vulnerable to the system. Studies estimate that as many as 1/3 of nursing home transfers are avoidable. This is due to patients and or families becoming anxious when a symptom exacerbates and a nursing home receiving pressure from families to seek immediate treatment. These figures have cost New York State alone $1.24 billion. Try to understand the transitions that take place between emergency departments and nursing homes. We have to look at what components are most essential in transitional care. One of the essential components is communication of accurate information. In order to provide quality care to all patients who transfer between settings within the healthcare system, communication needs to be clear and as close to real time as possible. Information should be up to date and accurate. An effective team is needed to collaborate all the components needed for placement. Communication among each member becomes essential. Each one has its own role and comply with regulation requirements. Example, a physician's diagnosis a patient, a case manager works on the patient review instruments for placement, social workers initiate psychosocial assessments, practitioners gather lab reports and initiate physical therapy consults, and a pharmacist reviews medication lists. These are all key components to initiating the process. The lack of crucial information can result in delays of care, inappropriate care, or errors that can lead to a sentinel event, such as death. Two crucial components of medical information needed to care for the frail older adults are up-to-date appropriate medication lists and advance directives. Administrating the correct type or dosage of medication for some patients can result in either prolonging life or can be the cause of death. The plan of care of symptom and pain management relies on the medication list being available, concise, and legible. Nursing homes will not accept a patient without a medication list. This is a vital part of their treatment process. During the transfer process, the lack of appropriate documents can result in delays of discharge and frustration for the patient. In the emergency department, advance directives are pertinent tools needed for patients in distress and provide a gateway of clear medical care during a time of crisis. Having these directives allows the medical team to acknowledge the patient's wishes of not to resuscitate or not to intubate, time when they are unable to communicate. Seeing a loved one in distress or with complications is stressful to any family and can lead to a crisis. Families in crisis don't have the capacity to make quick decisions or feel overwhelmed or burdened on making decisions on behalf of their loved ones, fear that they will make the wrong one. As advanced today, our advancements in health information technology of exchanging medical records via the National Health Information Network has ultimately improved patient safety. We are able to receive information faster and in a legitimate, legible format. There are some keys to improving the transitional care between emergency department and nursing homes. By increasing communication between sending and receiving clinicians, we minimize errors in patient care and increase effective documentation between institutions. Due to the rapid pace of transitions, patients and families feel unprepared, uninformed, or confused. Preparation of the patient and the caregiver for transition provides the opportunity for everyone to feel like a valid participant in the process. It reduces anxiety of the unknown and clarifies expectations, provides a clear understanding of the operational process. Having a liaison between the emergency department and nursing homes provides direct contact and advocacy for the patient. Emergency department workers are visiting more nursing homes to obtain information on the admission process and have a visual of the organization. Patients are reassured when staff members are able to describe in detail the aesthetics of a facility, the services it offers, and an explanation of the transfer process. Another key step in improving transitional care is the reconciliation of patients' pre- and post-hospitalization medication lists. Especially in the older adults, where the average number of medications per day consumed is 10. The interactions of 3 or more medications simultaneously can affect an older patient's balance and coordination and mental status. Once a patient is ready to leave one healthcare setting and transition to another, the arrangement for a follow-up plan on outstanding tests and follow-up care with the receiving physician is essential for an effective discharge plan. It's important for a patient to have a clear understanding of their goals of care. The interdisciplinary teams in both the emergency departments and nursing home have the responsibility in discussing with patients the warning signs that might necessitate further, more emergent medical evaluation. This provides the patient with the knowledge necessary during a time of crisis. After all, an informed patient is a happy patient. I would like to present a case example of an older woman named Mrs. X, who was in crisis and required a nursing home placement. Mrs. X is an 88-year-old Cantonese-speaking woman who lives alone. She has moderate dementia, auditory and visual hallucinations, and chronic medical ailments. She called 911 due to not having food in her apartment. A language interpreter was used to communicate with Mrs. X. To the interpreter, Mrs. X was unable to appropriately respond to the questions asked in my assessment. She would repeatedly spell her name or say, "I don't know." Due to poor memory, the patient was unable to administer herself medication properly and unable to recall she had food at home. She had to acknowledge she had a nephew and provided permission for me to communicate with him. Mrs. X had a physician she had not seen in years, no mental health services, and limited home care hours. I quickly assessed for safety at home and ruled out neglect. Her nephew acknowledges Mrs. X has hallucinations, but attributed this behavior to old age. He also felt that the patient calling the emergency response system was due to anxiety, probably not being able to reach him, as he's the only living family member. The dilemma in working with a family who didn't acknowledge the progression of a patient's illness. Due to cultural beliefs, the family preferred to maintain their privacy and originally declined acceptance from outside disciplines. Mrs. X also exhibited much agitation during her visit, and although care volunteers were contacted, she became aggressive in behavior. Due to financial constraints and family's inability to provide additional support at home, it made it difficult to provide a safe plan to return her back into the community. I asked my interdisciplinary team to have a pharmacist review her medications, initiated a psychiatric consult, discussed with the physicians the cultural and language barriers to placement, and provided explanation to the family about the process of nursing home placement. After much discussion regarding choice of agencies and assistance with locating appropriate facilities, the family was in agreement to placement. The medical team and I began the process of communicating with nursing homes and initiating the process. Even though the patient remained overnight, we directly intervened in a crisis and provided a safe plan of care. The emergency department was able to avoid an admission. Thank you.
Thank you very much, Gabrielle and Liza. To open it up for questions from the audience. If you have any questions, please feel free to type them in the chat box, and then I will read them to the speaker, and they'll address them. While people are thinking of questions and typing them in, I was intrigued. Well, first of all, both of you had to share with us today is such important information, and really reminded me a lot about why I went into this profession in the first place. The art and the skill that both of you are talking about. Really thank you for that information and for that encouragement for social workers on the line. Gabrielle, you mentioned the possibility of sharing some information about crisis management with other staff as in part of an in-service or a potential in-service. Do you do it in sort of a very general sense, or do you talk about a certain kind of crisis when you've done that, or what have you found to be useful?
Do that in terms of a specific type of crisis, and I've done it. Well, for example, there are two people that have been here 17 years. I've seen a lot of changes, and we as a facility have done a lot of growing and development and expansion. I look at it in terms of when we have situations that are perceived as a crisis by our staff. For example, if a patient becomes suicidal, and we don't have, unlike in a hospital, so we don't have social workers available 24/7, and because we have, a fairly large number of patients, and of those patients, we have a risk of depression, and a suicide threat can come up at any time. And I wanted to empower the staff, but also to remove this element of what I perceive as a lot of times we sit down at night or very often on a 3-day weekend. And so I would come back in on Tuesday, and the staff would be in a panic. And so what I did was work with the clinical staff in terms of assessing the suicide risk, and work with the administrators to set up a policy and procedure of what we do if a patient verbalizes suicidal ideation. And I also set up some care plan, sort of a best practices care plan of what will we do if a patient is verbalizing that. I wanted to create a situation where the staff had a unified response, and where when they had this happen, they themselves would panic. An example of this was in cases where a patient is perceived as being, quote, on a dementia unit, if they were reported to the social worker as being, quote, sexually inappropriate, how would we as a staff, as a whole staff, respond to situations like that? So I became involved in working with administration and authoring a policy and procedure for sexual behavior in the nursing home setting, and how our staff would proceed to manage when the issue came up. I wanted to empower staff and keep them from panicking, basically.
Good idea. Real good concrete examples of specific kinds of in-services that probably would be welcomed in every nursing home in the country. A few questions have come in, and so I'm going to read this one. One of our listeners has written in, you stated that a third of nursing home transfers to the hospital are avoidable. In my experience, if a patient requests to be transferred to the hospital, we have to send them. What are your thoughts on this?
When it comes to patients who want to go to the hospital, it is very true. Yes, you would have to send them to the hospital, but sometimes patients panic, and they feel that a nursing home does not have the availability to provide all the care that they need at that very moment. And patients sometimes feel that they can receive a more comprehensive care in a hospital because of all the equipment that's there, the larger arrangement of staff, and the different disciplines. Realizing that many times the nursing home has their own medical staff and can provide usually the care that they need at that moment. But because they feel they're in a crisis, they feel that the only way that they're going to be able to get the best care would be at a hospital.
So what you're saying is that if a resident says, I want to go to the emergency room, of course you're not going to, that we're doing as a staff member then is helping to facilitate that. But if the transfer to the nursing home is a staff member's idea, might need to be discussed, or is this an emergency, or is this something that can be handled in the facility? I have seen some situations where some nursing homes are particularly short-staffed at night, and so sometimes they didn't have the staff to deal with some issues, and it was just frankly easier to send the person to the emergency room, or they'd call the physician and the physician would say, well, send them to the emergency room. And so I think you're right, Liza, that with the Affordable Care Act, a lot of the kind of knee-jerk sense to the emergency room are not going to be happening because there are different incentives, financial incentives. And so for many of our nursing home residents, transfer to the emergency room can be dramatic, especially I'm thinking people with dementia. If you don't have someone to send with them to the emergency room from the nursing home who knows them, I mean that's just, and the family's not able to meet them right away or something like that. It can be very upsetting for somebody with dementia.
Right, to encourage.
Pardon me?
We encourage the patients to remain in the facility that they're familiar with because they're familiar with their surroundings of the facility. They know the patient and they know the patient's care. They would speak with their staff and with the patient to determine whether or not this is an emergent need or if the patient is extremely anxious about wanting the primary care to be at the facility. So that would be a discussion. And also, Mercedes, just like you said, it also depends on the time of day this is occurring. If it's occurring during the evening or where there's a short staff or a switch of staff, this can also impact the decision whether or not they would stay at the facility or come to a hospital.
Question has come in. This says it's a question for Liza. We're doing a trial run on the POLST program in my facility soon. Do you guys implement the POLST form in your facility? And if so, has it been effective in improving transitional care between the emergency room and nursing homes?
Certainly, I am not familiar with the POLST. It's not something that we are currently using.
Okay. Gabrielle, any experience with the?
No, I'm familiar with that one.
Okay.
I'm not familiar. One thing I can say in terms of emergent decisions about whether to transfer to the emergency room, and of course it does often depend on time of day, but there have been many cases where if a resident or a family is getting anxious, that sometimes will drive an admission. But it's also been my experience that we, and by we mean, those of us who work in the profession in all disciplines, we take for granted what we know. And the family doesn't have the kind of medical background that we have. So if you say, for example, your dad has pneumonia, that pneumonia that can be treated very easily, and you would have a good outcome with oral antibiotics in your nursing facility. But the family, if they don't know that, they hear pneumonia and they think, oh my gosh, he's getting ready to die. And so a lot of times what I have seen is that a hospitalization emergency room visit is prevented if you're dealing with an anxious family, if you spend a little time with a family finding out, first of all, what they're afraid will happen if they don't go to the hospital.
Yeah.
And that's a very important question. What are you worried about will happen if you stay here? Because a lot of times you'll find out, and particularly if the medical staff is saying, we don't see any reason to send them to the emergency room, but obviously if the resident or the or the family are stamping their feet demanding to go, sometimes you're amazed at what you can find out. Such, for example, we have people with congestive heart failure all the time. We see that diagnosis constantly, but the family may never have even heard that term, and this is the first time they're hearing it. And they think, oh my gosh, congestive heart failure, realizing there's a big difference between, CHF that's being managed as a chronic ongoing condition and acute CHF. And you may spend some time, or not a social worker necessarily, but you may need to get an RN or the charge nurses to visit with the family and provide reassurance that no, just because you have the diagnosis of pneumonia or just because you have a diagnosis of congestive heart failure does not mean that your death is imminent. Because people don't know, and a lot of times they can't know that unless somebody who has information tells them. So I think the education piece, exploring about the fear and then providing the education and reassurance that truly is what's going on. Said that, I also know that from, there are some families that it doesn't matter how much reassurance you provide, they are not going to be happy until they get into the hospital. And so we do come up against that. But I do, in my experience, there are a lot of hospitalizations or emergency room visits that can be curtailed appropriately when the whole team is working together.
The thing that I have found is that sometimes when a nursing home resident is transferred to the emergency room, they have a whole new cast of characters involved, medical characters, and I mean that in the nicest way, but they may have a different interpretation of what's going on with the resident, and they may or may not be really familiar with working with very old people and advanced chronic illness. And I've had families wondering if nursing home wasn't providing good care because of the thing they heard in the emergency room. Oh, all the bruises.
All the time. Yes.
Yeah. So people who are on certain medications, Coumadin or whatever, you're going to bruise more easily. Or so sometimes the persons in the nursing home are much more familiar with working with older adults and people with advanced chronic illness. And so working with the families to help them understand where is going to be the best source of information and support for them. And sometimes it's the nursing home and sometimes it's the emergency room, depending on the circumstances.
Exciting
go ahead.
In Houston is we have fortunately it's opened up very close to my facility. We have a hospital who opened a specialized geriatric emergency room. So it's as well as they have geriatric floors of the hospital, recognizing that need, because prior to them doing that, we would send a patient over, and of course they would be, if it was a Saturday night, they'd be in with the gunshot wounds, and it was very traumatic. Well, since they have opened the geriatric emergency room, it has really improved treatment outcomes and also just reduced the amount of trauma that the families and the residents are experiencing in their emergency room visits.
I think we're going to be seeing that throughout the country popping up, emergency rooms, especially for older adults. I wanted to go back to the question for just a moment about the POST form, standing for Physician's Orders for Life-Sustaining Treatment. We will be having a session in February that includes a case study with MOLST, which is the New York State version of it. There's probably about half the states in the country have this kind of physician order, and it has been proven in some states to help the family and the resident and the nursing home clarify whether or not the nursing home resident wants to be hospitalized, wants to receive CPR. It's like the advance directive, but it's a physician order. And so when another medical professional incurs it, they act on that order. So in some respects, it really has streamlined people getting the kind of care that they would like, especially for people who you wouldn't be surprised if they would die within the next year. So very a narrow tool. Any other questions or comments from our listeners, please go ahead and put them in the chat box, or Liza or Gabrielle, do you have any other thoughts you'd like to share?
Not at the moment. I'm interested in. But what was the acronym that they mentioned?
POLST, POLST.
POLST.
So,
okay.
The Physician's Order for Life-Sustaining Treatment started in Oregon, and then if other states take it, accept it, and change it in any way, then they change the name. So in Iowa, we call it the iPost. And it's the MOLST someplace, and it's different. It's called different things in different states. It's just getting started here. We've only had it about a year. So it's but other states have found it to be quite useful, especially for people in nursing homes. Um, so hopefully other states will find it useful as well. I had to ask both of you, since you've got such a nice background in social work, about how long were you in the setting before you began feeling like you really knew what you were doing, or that you could really handle whatever was going to be thrown at you in your work settings? Could we start with you, Gabrielle? Could you give us just a bit of an idea about how long it took to get settled?
I would say, I mean, honestly, probably about 2 years. Things started getting better after a year and a half. My first year in the setting was very difficult, and every other social worker that we've had here has expressed the same concern. It's an adjustment. It's a huge adjustment. And the thing that really helped me tremendously was being able to. My facility is very unique in that we have other social workers working, so I was not working as the lone wolf. If I'd been, I don't know that I would have been able to stay here unless I had hooked up with some other, and that's why I think this forum is so great, because you are in effect creating a network for other social workers who are working in nursing home settings, and it is a very specific type of social work practice, and it really helps just to norm your experiences with colleagues. It's tremendously valuable, and certainly that 1 year, 1.5 year adjustment that most of us face over here, and I mean, speak quite openly and candidly about. I've also heard about it not just in nursing home settings, but I've spoken with other MSWs in particular, people who come out with a master's degree in social work, and for the first after they come out and begin to practice, a kind of a remorse or almost a depression. Some people refer to it as depression sets in. That also occurs with other types of degrees as well. Architecture, law students. It's I think a process of realizing that that the honeymoon is over. That everything you thought that was going to happen once you got the degree is not necessarily going to happen. And so you're learning about the profession in a frontline kind of way, and your illusions about the profession are in the process of being broken down. And it takes just a lot of courage and a lot of stamina to stay in there through that process and come out on the other side of it, and realize that it's an incredibly worthwhile profession. And it's also important, again, I'm going to repeat this, it's important to connect with other colleagues to talk about what's going on with you, to talk about what's going on in your practice, to talk how you're feeling about what's going on in your practice. It's very important to be able to vent and have a colleague hear you and have some sense of what you're saying and why you're saying it.
Thank you very much. That's helpful. Is that about how long were you in the setting, in the emergency room, before you started feeling comfortable?
Well, interestingly enough, I came from a setting where it was completely different. I had absolutely no experience in the medical setting. I came from a foster care, working with children, and went completely in the opposite direction in a medical setting where I worked with 21 and over, and now specifically with 65 and older. So I've made a complete transition and turnaround, 180, in my field. But I would have to say, unlike Gabrielle, who had the wonderful opportunity of having others assist her through the process, I actually had just a few days actually of training and was actually alone pretty much through the process in the beginning. So I actually got acclimated pretty quickly in the medical setting. So I would say within a 6 month to a year, I was already familiar with terminology, the medical terminology, understanding the process of what patients experience coming into the hospital. having the support, I think of being there as long as I have, I think the support from both my social work department and my emergency department, I've been blessed. It's been a wonderful opportunity. And I think I say I have the best of both worlds because I have the opportunity to have the education and the support system and the networking my social department as well as from my colleagues within the emergency department. And it just provides the opportunity to really work together as a team, in helping our patients. And it's definitely been a learning process. The field just provides so many opportunities for us to further our education. As I have found that I've been interested in different areas of expertise, I've noticed that it's been best for me to continue my education in these certain areas like family and counseling therapy and the palliative care. And as the years go by, you learn that there's something else that, fascinates you and you want to learn more about. And that's kind of been my experience in the emergency room. It's just open a practice where you are working with patients of all different diagnoses and all different illnesses. I have the opportunity to actually learn a little bit about everything, and I'm actually fascinated by that and welcome anyone who really likes the unpredictability of what they can bring to really, enter this area because it provides an opportunity for much learning.
Wonderful. Gabrielle, Langley, and Liza, Ronda, thank you very much for your time and sharing your expertise. And those of you who've been on the call with us today, thank you very much for your attention and your questions. And we are signing off for today. Thank you.
Thank you. Thank you very much.